Okay, so we'll start with from here. So these are the ISMO treatment algorithm for B-cell ALL, which is, I think, similar to what we do in the US as well. So the first thing when we have a newly diagnosed B-cell ALL is the question if this is pH positive or negative, because the treatment is different. For pH positive, TKI remain the mainstay uh, backbone treatment. There's some variation, either the backbone chemo versus blinatumomab as an immune therapy. And nowadays, there's studies where they're using even inotuzumab as part of the initial therapy for pH positive ALL. But I mean, clearly, I mean, the blinatumomab chemo-free regimen is gaining more and more interest. At least in the US, we're seeing more patients being induced with immune therapy-based induction. And this may be even change in Europe, as there is the Italian study will be presented in ASH this year. For pH negative ALL, I mean, still chemotherapy is the main treatment, and we have blinatumomab approved as a consolidation therapy along with chemotherapy for patients who achieve MRD negative. This is mainly in young patients. In older patients, I think the field is evolving, and we'll see the results of the Golden Gate study if blinatumomab become the frontline therapy with low-intensity chemo in older patients. The use even of inotuzumab as a frontline therapy in older patients. It's also gaining some interest in the US, although it's not FDA approved. Now, after initial therapy, it depends on the MRD response, on the genetics of the disease. There may be a decision to take patient to transplant consolidation. For relapse refractory disease, this is also an area that is evolving rapidly as well. Um, I mean, I think at least in adults, we haven't been using many chemotherapy salvage for patients who relapse in pH negative ALL. We're used to, we start actually moving quickly to immune therapy. But this is also evolving as we're using more blinatumomab as part of the frontline therapy. So the question is, this is CD19 negative or positive? And then the question, CAR versus inotuzumab, then would you transplant these patients or not? I mean, still standard of care to transplant any relapse refractory patient with ALL once they achieve remission if they are transplant naive. But there is some suggestion that CAR can be curative in this setting as well. For pH positive, it depends which TKI was used. I think as we're using more third generation TKI in the US, which may be not the same in Europe and other places. If the patient failed ponatinib, then, I mean, most likely additional TKI will be less effective, although there are some promising ones like olverembatinib that seems to salvage some patients who failed prior ponatinib. Plus, also depends if plena was used as a frontline therapy, would you move to CAR or other therapy in that setting? So, I mean, despite all these therapeutic advances in the frontline therapy, I mean, we still see relapse in adults. And unfortunately, we're not curing as many adult patients with frontline therapy as children with newly diagnosed ALL, but definitely outcomes are improving. And with improving actually frontline therapy, we are transplanting less patients in CR1. And I don't know if you guys remember, there was an article maybe 12 years ago by Dr. Foreman and Rowe where they talk about the myth of second remission. And at that time, we didn't have any effective salvage immune therapy. And they were kind of arguing, you know, if you have a high-risk disease, you should try to transplant the patient in CR1 because once you relapse, only a small proportion of patients they able to achieve remission and be able to cure them with transplant at that time. Now, I think this is changing as we have very effective immune therapy in the relapse refractory setting. And you could argue actually nowadays, you're able to achieve second remission. The majority of patients take them to transplant in second remission or beyond. So I think the availability of effective salvage immune therapy um, improve the chances that the patient with relapse refractory disease able to receive transplant. Again, there's still high risk of relapse after transplant in this setting. And the availability of TKI, I mean, if you look at the initial study comparing chemotherapy versus chemo and TKI, newly diagnosed Ph-positive ALL, you'll see patients who receive TKI were able to be transplanted more frequently because you're able to achieve remission, maintain the remission for the transplant to happen. Now, with more potent TKI, with introduction of plena, maybe we are transplanting less patients with newly diagnosed Ph-positive ALL. But again, I mean, even with transplant nowadays, unfortunately, as we're transplanting, I think, higher and higher risk patient, relapsed after transplant remains significant, and it's the major cause of treatment failure. Now, with all the excitement about CAR T-cell therapy in the relapse refractory setting, and potentially it can be a curative therapy without consolidation with transplant, the reality that at least in adults, half of the patients, they will relapse in the first year. So there is some room to improve outcomes of CAR T-cell therapy in the relapse refractory setting. So, I mean, as most of us are aware, I mean, MRD remain the most prognostic factor that predict outcomes after transplant. And it has shown that the more sensitive the MRD testing, the better ability to detect low level of disease before transplant, that's still actually prognostic. This is a study done by Stanford and Oregon. And they show that clonoSEQ positivity, pre and post-transplant, is predictive of relapse after transplant. And the risk of relapse kind of correlate with how much this MRD burden you have before transplant. And in transplant, typically, most of the relapses happen in the first year. The same thing is applicable even for CAR T-cell therapy. They show actually having any MRD positivity after CAR is prognostic and predicts subsequent relapse. This was shown with obe-cel when they look at day 28 clonoSEQ results, but also was shown in children who received T-cell. If they maintain clonoSEQ negativity by 3 months from CAR T cells, their outcomes are excellent, and the chances of cure is high without any additional consolidation. So with this risk of relapse after transplant, this is what motivates, are we able to prevent the relapse by actually providing some maintenance therapy, especially that most of the relapses happen early on in the first year, before the graft versus leukemia effect kick in. So you need to kind of maintain disease control until the donor T cells recover and able to take over and prevent relapse by eradicating any residual disease. Now, some established strategies, you have the tyrosine kinase inhibitor in Ph-positive ALL, and this was used as a preemptive, where you monitor MRD, and once the MRD become positive, you start tyrosine kinase inhibitor, but also can be given as a prophylaxis regardless of developing MRD relapse after transplant or not. The other mechanism that has been used is donor lymphocyte infusion. More frequently is used as a preemptive, either because the patient lost chimerism or the patient developed MRD relapse, and it is mainly effective if you have a low level of disease. If you have full-blown relapse, typically donor lymphocyte infusion doesn't work well, but it comes with the risk of graft versus host disease. You need to collect the donor. So there is additional steps to be able to provide donor lymphocyte infusion. But there are some innovative strategies. You have immune therapy. I mean, there's many people excited about immune therapy as a way to kind of prevent relapse after transplant, because the challenge after transplant, patients, they tend to be more sensitive to treatment. And if you have a effective, safe treatment, this will be kind of motivate physician to provide to the patient. So these are some of the consideration for maintenance therapy initiation. I mean, it depends on the disease risk of relapse. It's based on the cytogenetic, molecular. We worry about certain subtypes of B-cell ALL like PH-like, KMT2A, TB53, hypodiploidy. We anticipate the risk of relapse is higher, although there are some transplant studies shows actually genetic risk doesn't increase risk of relapse if the patient go through transplant. But I think the most important thing is disease status at transplant. And there are two things. This is the first remission versus beyond CR1, like CR2, CR3. We see the risk of relapse is higher. And these are usually patients, high risk of relapse, and maybe more kind of eligible for post-transplant preventive strategy, but also MRD detectable pre-transplant that can be by MRD flow, by NGS, MRD. This usually predict high risk of relapse. But also the intensity of condition regimen. Patient with receiving a reduced intensity, non-myeloablative, conditioning at high risk of relapse compared to myeloablative. And we have seen this like in pH positive ALL, if they receive reduced intensity transplant and you give TKI after, the risk of relapse is low compared to patients who have pH negative ALL, receive reduced intensity transplant, we see higher risk of relapse. Then, I mean, we have to take into account if the patient develop kind of post-transplant complications, either slow recovery of blood cells, they have ongoing toxicities, either infection, GVHD, organ dysfunction. This may limit the ability to to initiate maintenance therapy. And also the characteristics of therapeutic agents. Do they have any mutation that you can target with gentle therapy, like tyrosine kinase inhibitors, menin inhibitors, potentially, for patients with KMT2A rearranged disease? So I think the most established approach to prevent relapse is tyrosine kinase inhibitor in pH positive ALL, because these drugs are highly effective in this disease. At the same time, they're safe to give. So usually the majority of us, and we'll hear how you guys feel about that, but the majority of us, we typically give tyrosine kinase inhibitor after transplant for pH positive ALL. And typically this is irrespective of MRD status. We give it more as prophylactic rather than preemptive treatment. However, the optimal duration of tyrosine kinase inhibitor maintenance both allo remain undefined. Some studies shows 1 year is enough, other studies 2 years. Others, they try to give it as long as the patient tolerate the tyrosine kinase inhibitor. And in one of the large retrospective study, I think this is from the EBMT 473 patient with de novo pH positive ALL, they show for patients who received tyrosine kinase inhibitor after allo, this led to significantly improved leukemia-free survival and overall survival, and led to lower risk of relapse in these cases. Donor lymphocyte infusion is another modality to reduce relapse after transplant, and this has been actually described by different groups. Again, the main concern is the risk of graft versus host disease. And typically, it's more likely to be given for MRD relapse or loss of chimerism rather than prophylactic. But although there are some small reports where they use it as a prophylactic, but again, you have to collect the patient, and there is a risk of GVHD. In this study, they show the risk of significant acute GVHD wasn't too high, only 14%, but it appears to be kind of have an efficacy by reducing the risk of relapse, but this is a small study. There are more excitement about immunotherapy, as we mentioned, and this is one study where they used blinatumomab. This is from MD Anderson. It's a phase 2 study. They had 21 patients with high-risk B-cell ALL, where they plan to give 4 cycles of blinatumomab after transplant. Now, only 57% of patients able to receive the full 4 cycles. I couldn't tell from the article why the rest didn't receive it. And they found there is correlation between having higher proportion of effector memory CD T cells and the response. And for those who relapse, they have T cell deficient that express more inhibitory checkpoint molecules, include TIM3. Now, when they compare the outcome of this phase 2 study with the historic control that was kind of matching characteristics, actually they report that this approach of blinatumomab maintenance wasn't better, was comparable to the previous cohort that didn't receive blinatumomab maintenance. But you can say that blinatumomab maintenance was safe overall. The risk of GVHD was low. Again, I mean, it is an I mean, there was some excitement about the study, but it doesn't seem that's truly improve outcomes and decrease risk of relapse in this setting. Another approach is inotuzumab, and there was this phase 1 study that I think was led by maybe Case Western, Cleveland Clinic. There was also University of Washington, where they tested low-dose inotuzumab given once a month in the first year of post-transplant. And there was a dose escalation. They believe they started with 0.3 and they reached 0.6, if I'm not mistaken. But they select for high-risk patients, although, I mean, many of them, they were RCR1 when they went through transplant. And the treatment was safe. I mean, the main concern of when you kind of talk about inotuzumab and transplant is the risk of SOS. But there were no cases of SOS when inotuzumab was given at low dose once a month. And the non-relapse mortality was low. And 1 year overall survival, PFS, were encouraging, actually. So there's some interest in this. People are excited about this approach, but I think we need larger cohort for this to kind of gain momentum for people to start using. Another approach is to give CAR T-cell therapy for high-risk patient after allo. So this is an experience from China where they treated 23 patients with high-risk B-cell ALL, including patients who had active disease or MRD positive before transplant, and they received donor-derived CAR T cells. They have seen CRS in 40% of patient grade 1 and 9% of patient grade 2, but no grade 3 or 4. I don't recall there were no neurotoxicity after CAR in this study. But this approach actually shown to be kind of promising as the risk of relapse was lower compared to historic control. And this approach was associated with higher BFS and overall survival compared to historic control. So I think there is an interest in this approach. Stanford, they have a study they present, I think, early data last ASH, where they use the ORCA graft transplant and they give CAR T cell therapy after the transplant. And they show some kind of early promising data. At least it is safe. At CityFob, we have an approach where we actually manufacture CMV donor-derived T cells to make them CD19 CAR. We give them after transplant. Then we'll try to expand these CAR T cells by a vaccine afterward. So there is an interest in this approach because CAR is the most effective therapy, and using donor-derived T cells to manufacture, they are healthy. We're having less risk of GVHD. It is an interesting approach. So current relapse prevention strategies in CAR T cells, again, as I mentioned, I mean, half the patient at least relapse after CAR. So there is an interest also how we can improve remission durability and decrease relapse. I think the most established one is to do consolidation with transplant after CAR T cell therapy, the one who responds, especially for transplant naive patients. The concern is early and late kind of complication of CAR, including transplant, including non-relapse mortality. But it is an effective approach. But people sometimes reluctant to do the transplant because the risk of complications and the fact there are some patients can be cured with CAR T cell therapy alone. It becomes more complicated for patients who relapse after transplant and you're thinking of second transplant. Now, for patients who relapse after CAR or they cannot lose the B-cell aplasia, there has been some approaches where you give the CAR T-cell therapy again. It doesn't seem to be very effective approach, at least in kind of improving the remission durability. It may achieve remission again, but again, typically relapse happen quickly. There is approach where you can give T-cell antigen presenting cells to stimulate in vivo CAR T cells to expand and persist longer. And there is also the humanized CAR T cell therapy, where sometimes you lose CAR T cells if using murine-based CAR T cell therapy by developing antibody to clear the murine-based CAR. The humanized is supposed to last longer as these are humanized CAR. And there are different studies looking at humanized CAR in CAR naive as well as CAR exposed patient. Data seems to be encouraging. There are some reports where there may be increased neurotoxicity. So that may be another approach. But also, one of the challenge with CAR is the relapse with CD19 negative disease. So a humanized CAR doesn't address that. Reinfusion of CAR doesn't address that. So we have to kind of think about how to prevent that. And some studies where they do dual or bispecific CAR T cell therapy to target the leukemic cells from different antigen. And the use of TKI on target agents. I mean, I think using for patients with pH positive, if they're still TKI sensitive, we're seeing that these patients actually do well if they receive tyrosine kinase inhibitor after CAR. The concern, well, these TKIs actually get rid of the CAR T cells early on. So many of us, we wait a couple months before we start TKI. This is applicable for pH positive, but could be applicable even for menin inhibitors in KMT2A rearranged cases. Yeah, so I mean, the concern is relapse after CAR, and it is the phenotype will determine subsequent treatment. I mean, if it is CD19 positive relapse, the question, what do you do? Chemotherapy, I think if you reach the point where you receive CAR T cell therapy for relapse refractory disease, unlikely chemotherapy will be effective after relapsing from CAR. Looking for other CD19 target therapy, maybe humanized CAR, blinatumomab. I mean, there's not a lot of data that blina can salvage relapse after CAR infusion, and humanize, as we mentioned, they have their own limitation. Looking for other target like CD22 target therapy, inotuzumab. But I think there's some interest in experimental approaches, including new bispecific. We have the AZD0486 seems to salvage patient after CAR T cell therapy relapse if they still CD19. And there is the other bispecific antibody, I can't remember the name at this time, and it seems active. And there will be actually an ASH presentation this year, oral presentation. And it seems patient can relapse after CAR, they may still respond to this novel bispecific. That could be also applicable for sub-Q blina, although not many patients, they failed CAR T cell therapy in the latest presentation. I think the more challenging thing is the CD19 negative relapse and the lineage switch. And options usually limited. You have to look for other targets like inotuzumab, maybe an option. There may be some experimental options we're presenting on BAFF-R CAR T cells, especially in patients who relapse after CD19 negative disease, and we're seeing responses. So I think this will be an area that we will see more and more CD19 negative relapse as we're using blinatumomab early on, as we bring CD19 CAR T cell therapy early in the relapse setting. It's going to be a challenging situation that we will need actually more target therapy beyond CD19. And you have the lineage switch that can happen in some cases after relapse post-CAR. And it's a very high-risk disease. And options, usually chemotherapy that geared toward AML, Veneza was used, CD33 target therapy is another option. Experimental, the problem maybe many studies will exclude these patients from from enrollment. And I mean, whenever we're able to achieve remission, I mean, the only chance to cure these patients is to do transplant. So in conclusion, allotransplant continue to have an important role as a potentially curative option for patients with high-risk ALL. Relapse following transplant remain challenging, with several studies exploring preventive measures post-transplantation. And established therapies such as tyrosine kinase inhibitor maintenance in patients with pH positive have been shown to reduce the risk of relapse. And we're hoping we'll have, with more kind of targeted options for our patients, newer strategies, including the use of blina, inotuzumab, prophylactic donor-derived CAR T cell therapy in patients with B-cell ALL, have shown promising initial activity, and optimal strategies to prevent relapse and for salvage therapy following CAR T cell therapy remain to be defined. yeah, it's still a challenging situation. I mean, for now, it is mainly transplant, but we're seeing actually that TKI, maybe for TKI sensitive pH positive ALL, they benefit from receiving this approach, especially for patients who relapse after transplant and you're not thinking of second transplant. Next slide, please. Okay, so these are the discussion points we're hoping to cover today. The first one is, what factors do you use to select patient for maintenance therapy after allotransplant? Dr. Ribera, do you want to tell us what factors usually when you decide on maintenance therapy post-transplant?
For pH positive ALL, it's clear, the TKI. The problem is the pH negative ALL. So it's difficult. We do not do any maintenance therapy post allogeneic transplantation, but we are aware that there is increasing risk, about 30% of relapse after allogeneic transplantation. So I think that the best issue is to prevent the relapses, to identify those patients who are at high risk, and then we'll use preventive measures. We have activated now in Spain a trial with inotuzumab post-transplant in patients with high risk of relapse after transplantation in first line. So it's just being in the process of activation. It's not fully activated. That's what we do, no more.
So for the eligibility for the study, any pH negative, regardless of CR or MRD or genetics, they're eligible to receive post-transplant maintenance?
Yeah, we identify a priori the patients who are at high risk after transplantation. So so especially by genetics and MRD level before transplantation. These are the two main factors, and these patients will receive post-transplantation and will be compared with a concurrent cohort of patients that will not receive any measure after transplantation. That's the goal. It's not a randomized study, it's just conducted in parallel with our assistential trial that does not have mandatory maintenance therapy after transplantation or preventive therapy after transplantation.
Yeah.
May I ask a question to Dr. Ribera? This is Andre.
Yeah.
Hi. Will the level of MRD pre-transplant is a criteria for having INO after transplant?
Yes is one of the criteria. Another is the genetic background. KMT2A, low hypodiploid, especially.
etc. Okay.
Joseph, aren't you concerned about hepatic toxicity in giving the INO?
Yeah, we will use 0.5 milligrams. So this is the safe dose identified in the MESSENA study.
This is a flat dose or milligram per meter square? Flat?
No, milligrams square meter, yes.
Okay.
It's the dose that was considered safe in the phase 1 trial by the only trial to date, published to date.
Andre, do you have any studies in France for maintenance in pH negative BCLA?
No, we do not. I must say that pediatricians have tried to kind of preemptive blina in case of rising MRD in Europe, and this trial has failed to activate. And some, let's say, difficult cases, clinical cases where the failures were not really understood in terms of toxicity, have made this trial finally impossible to activate. So At the moment, I would say that obviously we try, but as you know, access for children is really limited. When for KMT2A, we would love to have menin inhibitors after transplant. But at the moment, whatever in ALL or AML, we have not access to these drugs. So even after for maintenance, it would be a challenge for us. But I do think obviously it's a good idea.
Dan, what about you? I mean, what do you consider for maybe maintenance approach post-transplant?
So I'll take a slightly different approach. I would argue, with all due respect, that there's no data that maintenance works. I mean, there was an old Jemima study that looked at empiric versus prophylactic or maintenance or initiation of TKI. That is, everybody gets TKI versus you start at TKI only when the PCR turns positive, and there was no difference in outcome. Having said that, we still use TKIs post-transplant, and it's the same problem with AML. Right? I mean, there's a lot of studies out there, and all the studies show that, based on historical comparators, no randomized studies, but based on historical, the patients do better, but it's all selection. And I think that's the problem we see in ALL. We were part of the inotuzumab post-transplant maintenance, and we had because of thrombocytopenia, reduced the dose significantly and spread out the instead of every 3 weeks, every 4. It was tough to get in because of count issues. So Jose, just be cautious of that. We didn't see a lot of VOD, but it was more thrombocytopenia and count problems. I think the times are different though, Ibrahim. I mean, now patients are going into transplant. Most patients, not all, but most patients are going in pretty deep MR, if you can, deep MRD. So, the outcomes are very different. I was reminded of the study that of the slide that you showed in terms of second transplant outcomes. Remember, and I'm sure as you elucidated, the ECOG 2993 data, the LALA 94 data, it didn't matter. The relapse was just awful, whether you treated with chemo or auto or allo, nobody did well. Second CR, it was a fallacy. Of course, now it's a little bit different. So it's going to be interesting to see. But we really need randomized studies is the issue, is what I'm trying to get to, because the field has changed.
Yeah, I mean, the concern, Dan, I agree with you. Now we're achieving very deep remission in CR1, but the problem, the one we transplant, I mean, they're really truly high-risk patients. I mean, we're transplanting less CR1. Now we're transplanting more CR2, more CR3 patients who had induction failure. So, I mean, I think we're having even a higher risk disease to transplant. So I think my expectation that we will see more and more relapse post-transplant.
Yeah, I agree. But the problem is, if you think about it from a teleologic perspective, what is maintenance? I've never really understood what maintenance does, right? Because if,
nobody knows. I can tell you.
I would argue it does.
ALL.
I would argue it does very little, right? Because in what you're doing is you're delaying eventual transplant. Because if the maintenance really is needed, that means the transplant failed and you have ongoing disease that you're treating. I'm in my mind, I'm trying to figure out what the heck are we doing? Early maintenance kind of makes sense because you're waiting, especially in a RIC allo, you're waiting for the transplant to evolve, for the graft versus leukemia to take place. And so, patients who have high risk disease or go in with MRD positive disease are at a risk of early relapse. But then we don't like to use maintenance during those first few months because of the things that you just said. We're using it later. And so I'm trying to figure out what the heck we're doing here, other than just delaying the inevitable. So I'm not, yeah, no, I hear, I mean, we all want to do something. It's just, I'm not sure that we're doing anything that makes sense. And all the studies are just fraught with small numbers and selection biases. So I hate to be so negative, but I look at maintenance in AML and ALL, and we participate in all these trials, but I'm always very loath to really draw huge conclusions.
Thank you, Don. Sabrina, want to tell us your
Well,
approach?
I mean, I would just like to make, and I think I'm speaking about on behalf of all Europe, because you
Yeah.
just presented very fancy data and everything is fantastic. On the other hand, so first of all, for pH positive ALL, I will present the data. So what we are trying to do is just to avoid transplant in pH positive ALL because the results are so nice and lately are becoming even quite consistent in terms of follow-up that probably we can avoid transplant to the majority of patients. So for me, the real issue is not to avoid transplant forever, but just to identify the persons that really need it. Can be ICAROS, can be the number of white blood cells, can be whatever we want, and we really have to look at the data. We do not give maintenance. In general, we are trying to give maintenance just in one trial for the pH positive ALL, sorry, for the pH like ALL, and for the rest, no, we do not give maintenance. And the other thing that for me it's really necessary to point out, I'm speaking about Italy, but I'm sure it's not only Italy, is that, for example, CAR-T, which are really appealing, we can give them only to relapse refractory patients. So in my, let's say, clinical practice, if I have a high-risk patient, even for biological feature at the onset, or because it took some time to get MRD, this patient will go to transplant. And if it relapse later, and sometimes, unfortunately, it happens, then it will receive CAR-T, possibly autologous, otherwise allogeneic CAR-T. Which for us are experimental because we can give allo-CAR-T just if we send our patients to Bambino Gesù, where Locatelli has his own factory for producing them. So all the rest is very fine, and I hope we will get this drug, or our policies will change. But otherwise, it's really sometimes quite difficult just to translate all this stuff in the clinical practice. I'm quite optimistic about subcutaneous blin, so we will see if I'm wrong or right.
Yeah, the only thing with subcu blina is the practicality. I mean, you have to give it 3 times a week. I mean, to be honest, I'm more excited about the new bispecific antibody.
Definitely, yes.
I mean, these ones you give it every 2 to 4
Definitely.
weeks, and it seems to be safe. I don't think subcu blina is that practical to give it after transplant as maintenance. Wendy, let's hear your thoughts about the topic.
Well, I came in the middle, but I have to agree with a lot of what has already been said, that I don't know the benefit of post-maintenance post-allo maintenance therapy at all. I don't typically use it. Except for in pH positive ALL, where I do tend to use it again when I can. And I think Dan's point is a really good one in terms of how do you have to introduce it right away, or can you introduce it later, or should you introduce it at all?
Which is something that anybody can answer, in fact.
Pardon me?
Anybody can answer to this question because everybody introduces TKIs whenever they want or whenever the patient
exactly
is capable of assuming this.
Exactly. And I feel like the data, it's true that I tend to try to, in those patients whom I transplant, which in pH negative ALL, which are really not that many, the highest risk patients, I really don't have a good idea of what to do. These are often, for example, ETP ALL, and I really don't know what to do post-transplant, and I tend not to. I try to optimize them going in with the hope that I don't have to do anything after, because I really don't know what to do. And it is, as everybody said, it's so hard to intervene early. If there was a good intervention, it's hard because you don't want to, you're trying to get them off immunosuppression. You're trying to get them back on their feet. And it's a complicated situation. So I tend not to, I haven't done anything in general except for hope for the best and monitor MRD. And if I have to, then I try to think of something with which to intervene.
Wendy, what about post-CAR? I mean, are you guys routinely transplant naive patients?
Post-CAR. Well, again, if it's post-allo, no, I don't try to go to another transplant. I try to avoid that. Pre-CAR, I mean pre-allo, yes. Then I have been taking patients, if I can, to an allo, if that's what you're asking. I don't, I still am not, yeah, that's my approach.
Yeah, we do the same thing. So if they're allo naive, transplant naive, we'll transplant them. But we've talked, as you know, Ibrahim, we've talked about this on many times. The majority of the patients who did not get transplant, they always say, oh, it's that CAR T cell is curative, but the reality is 2/3 of the patients had a transplant going into CAR, and so they didn't get a second transplant. So and as opposed to so it's kind of it's difficult to interpret when most of the
May
patients.
I say that the position of the pediatrician is not the same because we do not have access to the same product, basically.
Yeah.
Yeah.
You all know that in pediatrics and young adults, we, at least until 25, we have access to Tisagen Luclocel, and really some patients, and for us, our first patient now is 10 years after, had nothing else than CAR. So
Right, it's different
standalone
product.
therapy for persisting CAR is not a myth. It is possible. The question is, as you said, that maybe half of the patient will not have persistence. And those patients, particularly if you lose B-cell aplasia during the first 3 or 6 months and are naive to transplant, are really good candidates to transplant for us.
Andre, do you see there is a rule for maybe maintenance approach for, let's say, a kid who had a transplant, then they relapse, they receive T-cell, and maybe they lose the B cell, maybe not.
Thank you for the question, Ibrahim. As you may know, there is a kind of a consortium which has been established on both sides of the Atlantics, run by Nirali Shah, called INSPIRED. At the beginning, it was a kind of an academic meeting. We have published papers and so on. We just published, by the way, this week, an interesting paper about the language, which is how to define B-cell aplasia loss. So it's in hemisphere, and I give you the advice. But beside this publication, we are trying to embark on 2 trials. One trial is about maintenance therapy, and it will be a non-randomized, but at least controlled study about giving 6-MP methotrexate after CAR-T versus no. And obviously in the control arm, there will be also transplanted patients, but it's not randomized, but at least we will try to set up the control in a proper way. And this relies on the British experience published by Sarah Goratian and Laura Gabelli as a first author some years ago, where giving 6-MP methotrexate was giving as good results in the Great Ormond Street study, retrospective, possibly biased, blah, 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 but as good as transplant as a consolidative therapy. So this is the basis for at least a controlled trial, even if not perfect. And the second trial, which will be randomized, if we succeed to activate it, is about how can we increase the persistence, which is how can we improve the AUC for fludarabine. So it will be in one arm adapted AUC according to PK of fludarabine after the first injection, and in the other arm, the classical way to give flusam. And we will see if the adapted PK works better than the other one.
Yeah, Andre, I mean, I think some people may argue if you give mercaptibutrin methotrexate after CAR, you may get rid of the CAR T cells. And this patient chemorefractory, I mean, what's the point to repeat chemo?
Now, look, more and more patients received CAR for first refractory first-line ALL. And these patients have been not exposed so much to 6-MP methotrexate. And by the way, we don't know how this so-called maintenance, which is more continuation therapy, works. So you are right, there is a possible risk of killing or diminishing the action of CAR, but it is what we are going to do.
Yeah. Anita, what's your thoughts on the topic?
Yeah, well, I think I agree with the European guys because in the Philadelphia positive, we always give TKI after allo. And in the Philadelphia negative, we wait and let us guide by MRD. So if MRD sets up, but that's, you might not call maintenance therapy, but it's more treatment, then we start blinatumomab normally, but not preemptive.
Okay. And Charles, do you want to give us
Can I say just
how is the approach in St. Jude? Go ahead, Sabrina.
Sorry, because the other thing that we have to consider, I mean, we didn't speak about it, but it's something that for me in the clinical practice can be quite important. If the patient relapse, when does he relapse? Because there is a huge difference between a patient that relapses 5 months later, 3 months later, and a patient, sometimes it happens 3 years later, because that patient is almost chemo naive.
You mean for chemo or for transplant?
For both. I mean, lately I had few cases, but they're becoming quite much more, in which relapse are really late relapses, even after 5 years.
But
You know, I have seen after 25 years.
Yes, right. It happened to me. I mean, I had a patient that was diagnosed the first time when he was 5 years old, and he was re-diagnosed when he was 48 years old. Possibly was not even the same disease, but we couldn't prove it really because there was no left material. But so those are, let's say, anecdotal cases, but there is a huge difference between, let's say, relapse within 6 months and relapse after 2 years.
Thank you, Sabrina. Charles, do you want to tell us what you guys do in St. Jude for allo and for cell therapy as the maintenance?
Sure. Thanks, Ibrahim. A comment to that and maybe a question back to you. I mean, so we don't, I think, have a routine approach to maintenance post-transplant, but a couple of approaches that are being used are, and you touched on some of these, are initial dual antigen targeting. And so we have our own engineered 1922 product to try and, you know, increase efficacy, and we have our own backbone and to try and reduce the incidence of antigen negative escape. And the second is some ongoing studies with graft engineering, with CD45 selection to try and maximize efficacy, including, you know, selecting subsets of T cells to manufacture the CAR as well, but they're ongoing studies. If I can ask you a question, Ibrahim, and that is, you raised a couple of these points, but I'm not sure what you actually do at City of Hope. And do you factor in the genetic subtype of ALL in terms of making decisions about post-CAR T transplant consolidation or post-transplant use of therapies such as CAR T? Like, you know, if you have a very high-risk group, MLL rearranged, hyperdiploid, etc., or do you just treat all pH negative the same way and look at conventional factors such as B-cell aplasia, MRD, etc.?
You know, I take different factors. I mean, if you have like a standard transplant CR1, we haven't seen difference based on the genetics. It may factor in terms of KMT2A. We have study where we give menin inhibitors after transplant. But what I have seen for patients, like if they have an induction failure, if they have a CR2 or more, cases like TP53, PH-like ALL, they do worse than actually other patients, especially. It depends like what transplant you do. I mean, many studies showing that outcomes of post-transplant Cytoxan with standard methotrexate tacrolimus are similar. But the truth, if you have a relapse or refractory ALL going to transplant, I see more frequently relapse with post-transplant Cytoxan in these cases. And more likely would recommend to do actually maintenance approach after the transplant. We have studies where we use our own CAR T cell therapy, as I mentioned, and we select for CMV specific T cells where we have a vaccine. We can expand the CAR T cells after we give the CAR T cells. at CT4, but we select for high-risk disease, MRD positive before or CR2 or beyond. For CAR T cell therapy, I think genetics matter. There are several studies showing like TP53 mutation, they don't do as well with CAR T cell therapy. And we're seeing more and more TP53 ALL. I'm not sure why, but we're seeing definitely more and more TP53. Maybe we're looking more for it. And these patients, they tend to relapse more, and they relapse frequently as CD19 negative disease. So I tend to actually do transplant for these patients after CAR, including second transplant. The same thing with KMT2A, PH like ALL, I feel they relapse more frequently after CAR, and I tend to kind of do transplant, including second transplant in these cases.
Oh, I just had a very quick question to follow up on that. So many of those P53 mutant cases that experience escape are going to be hyperdiploid, and hyperdiploid cases are a subset that have, often a particularly good response to venetoclax. And so it's another agent that I guess we haven't touched on. And how do you think about the use of that in these patients in this context or generally?
Like as a maintenance, yeah?
Yeah.
Yeah, I mean, I think the MDS study, no, there's an AML study where they use venetoclax as a maintenance. The issue is the cytopenia, Charles, with venetoclax. But maybe this is a good thought, maybe something to consider.